Welcome to the video answers for question set 20. Let's get started. First question, a unilateral lesion to the lateral corticospinal tract results in motor deficits ipsilateral to the lesion. Where in the lateral corticospinal tract is the motor innervation to the legs located? It's in the lateral part of the lateral corticospinal tract. In the lateral corticospinal tract, remember, the arms are most medial and then the legs are most lateral. Next, what are some of the possible causes of pericarditis? So pericarditis is inflammation of the pericardium. And lots of different things can cause it. Very often it's idiopathic. Coxsackie virus A or Coxsackie virus B can cause pericarditis. So can tuberculosis, uremia, lupus, scleroderma, radiation of the chest. So maybe the patient received radiation therapy for lung cancer and that radiation affects the pericardium. Rheumatic fever causes pancarditis. That's one of the major Jones criteria for acute rheumatic fever, pancarditis. And pancarditis can affect all the layers of the heart, including the pericardium. And then another cause of pericarditis is Dressler syndrome, which is inflammation of the pericardium following an MI, usually several weeks after an MI. So the patient had an MI, he was treated and recovering, and weeks later he starts having chest pain again and he comes to the ER in a panic because he's worried he's having another heart attack. So the history is going to help you make the diagnosis there, but you're going to need to know how to distinguish pericarditis from ischemia. And then finally, you can also get pericarditis from cancer mets to the pericardium. Next, 22-year-old man recently lost his leg in a tragic accident involving alcohol and heavy machinery. Just prior to discharge, a vigilant nurse informed you that the patient has been very depressed about his lost limb, and she overheard him talking to a friend about just ending his life with his dad's gun when he gets out of the hospital. So what needs to be done? Well, first of all, you need to assess the seriousness of the threat and evaluate the risk factors for suicide completion. This patient has several risk factors, including male sex, depression, alcohol use, an organized plan, and access to a gun. Then, if you determine that a suicidal threat was in earnest, your next step would be to recommend to the patient that he stay in the hospital voluntarily for his suicidal ideation. And finally, if the patient refuses voluntary hospitalization, he can be involuntary hospitalized with a mental health warrant issued by the court as directed by the expert opinion of the physician. Next, in cystic fibrosis, thick mucus secretions inhibit digestive enzymes, which can lead to malabsorption of fat and fat-soluble vitamins. So what are the fat-soluble vitamins? Well, it's vitamins A, D, E, and K. And then what are the corresponding symptoms of fat-soluble vitamin deficiency? So vitamin A deficiency causes night blindness and also some dry skin. Vitamin D deficiency in kids causes rickets, which is bent, deformed bones. And then in adults, vitamin D deficiency causes osteomalacia and also hypocalcemia and tetany. And then vitamin E deficiency results in fragile red blood cells, muscle weakness, and demyelination of the CNS. And vitamin K deficiency causes coagulation factor defects, which can lead to heavy menstrual bleeding in women, anemia, bruising, bleeding gums, epistaxis or nosebleeds. And then also, low vitamin K levels are associated with osteoporosis and coronary artery disease. Next, what class of drugs can be used to treat estrogen receptor positive breast cancer? So, in addition to standard chemotherapy, you're also going to block those estrogen receptors in the breast using a selective estrogen receptor modulator, such as tamoxifen or raloxifene. Now, these drugs have different effects on estrogen receptors in different tissues. That's why we call them selective estrogen receptor modulators. So they antagonize estrogen receptors in the breast tissue, but over the bone, they actually act as estrogen receptor agonists. That leads us to the second part of the question, what's another use for these drugs? So we can use them for osteoporosis, especially raloxifene, because that's going to stimulate estrogen receptors at the bone, and that's going to assist in bone building. And then what's the main concern when using tamoxifen? Well, tamoxifen can increase the risk of endometrial cancer. Next, what branchial arch derivative abnormality causes facial abnormalities by affecting Meckel's cartilage? So you definitely need to know the branchial arches and clefts and the pouches for your test and know what they develop into. So Meckel's cartilage comes from the first branchial arch. And then what cranial nerves are affected in this abnormality? It's the second and third division of the trigeminal nerve. And from what germ layers are these branchial arches derived? So the branchial arches are derived from mesoderm and from the neural crest. So the mesodermal component becomes the muscles and the arteries, and the neural crest component becomes the bones and the cartilage, such as Meckel's cartilage. Next, which primary bone tumor fits each of the following descriptions? So the most common malignancy arising within the bone is multiple myeloma. The 1122 translocation is seen in Ewing sarcoma. Soap bubble appearance on X-ray is a giant cell tumor, also known as an osteoclastoma. Onion skin appearance of the bone is Ewing sarcoma again. Codman's triangle is seen on X-ray in patients with an osteosarcoma. It may arise from osteochondroma or appear as a primary tumor is a chondrosarcoma. Anaplastic small cells, aggressive mets, and good chemo response, that's Ewing sarcoma again. And then the most common malignant bone tumor in children is osteosarcoma. Next, how does an anterior shoulder dislocation present differently than a posterior shoulder dislocation? So let's start with the arm position. In an anterior dislocation, there's external rotation and slight abduction. In posterior dislocation, there's internal rotation and adduction. The patient's unable to externally rotate the arm. And then for neurovascular compromise, with anterior dislocation, it's the axillary artery and the axillary nerve that are at risk. With posterior dislocation, it's unusual to have any neurovascular compromise. Then the classic scenario for an anterior dislocation is a blow to the arm while it's abducted and externally rotated, and the arm is extended, so like you're blocking a shot in basketball. Then the classic scenario for a posterior dislocation is a patient who either has a seizure or maybe an electrocution with violent muscle contractions that basically yank the shoulder out of socket. And then for physical exam, with an anterior dislocation, if your patient's thin, you might be able to appreciate a very prominent acromion process, and you're going to see some loss of the normal roundness of the shoulder. It looks a lot more angular. With posterior dislocation, there's kind of a bulge in the posterior shoulder area, and the anterior aspect of the shoulder is relatively flat. Next, you're treating a 63-year-old woman with small cell lung cancer who develops SI-ADH. She becomes disoriented, secondary to hyponatremia. Consequently, you rapidly correct the low serum sodium with demeclocycline and water restriction. The patient's sodium level and disorientation improve. However, soon after, the patient is going to develop diplopia. So what's the cause of this patient's diplopia? Well, the problem here is that this patient's sodium was corrected too quickly. So while she was hyponatremic, she had some swelling of the brain tissue because the free water was going from an area of low osmotic pressure in the serum to an area of high osmotic pressure in the neurons of the brain. Then when the sodium was corrected, the free water is trying to balance all those shifts, and so the fluid is essentially sucked back out of the brain tissue. And that causes damage to the pons, which is called central pontine myelinolysis, or CPM. So patients who have hyponatremia that's corrected too rapidly are at risk for CPM. CPM can cause diplopia, can cause dysarthria, can cause paralysis. And in severe cases, you can have what we call locked-in syndrome, where the patient's alert and awake, but she's unable to speak or to move. It's pretty scary stuff, especially because that can be irreversible. Our last question, a 45-year-old woman receives a kidney transplant and receives cyclosporin as part of her anti-rejection regimen. What's the mechanism of action of cyclosporin? So cyclosporin is an immunosuppressant that's used for transplant patients. It's also used sometimes for things like psoriasis. It's used off-label for lupus nephritis. Cyclosporin works by binding to a protein called cyclophilin, which is found in the cytosol. And that complex of cyclosporin and cyclophilin inhibits an enzyme called calcineurin. Now normally calcineurin activates a transcription factor called NFATC, which stands for nuclear factor of activated T cells, cytoplasmic. That upregulates expression of IL-2. Then IL-2 is important for T cell growth and differentiation and activation. So cyclosporin inhibits calcineurin, so you're going to have less activation of that NFATC transcription factor and less IL-2, and then that's going to inhibit T cell growth, T cell differentiation, and activation. And on that note, we're going to end this question set. I'll see you next time.